Swayam Prabha. Digital India. Educated India.
Hello all, welcome back to our course on Precision Oncology. We have dealt several topics on many aspects of basics of cancer to cancer detection methods, immunotherapy. We've even studied in detail what exactly the CAR therapy. Now, what is the objective of the whole learning many aspects of precision oncology? That now we will really have a holistic approach towards cancer biology, towards the diagnostic procedures, and towards the treatment strategies. Now we are going to introduce to a very different term, precision medicine or precision and personalized medicine. It is more of personalized strategies, personalized targeted therapy, personalized treatment strategies. All these are more or less the similar strategies. Now, so we are know how does this work out in cancer. We are all very aware that tumors have different underlying genetic causes and may express different proteins in one person versus another. This is completely all agreed because we've been talking about for this several sessions. We check if a diagnostic marker is positive. What do we call them? If a diagnostic marker is not absent, we call them mutated. Now, if you are really like to know for a precision oncology or a targeted therapy, it is important to really have the concept that tumors are each tumor within the tumor per se, it's also entirely different. The cancer has an inheritable variability. So this is totally this particular precision and personalized medicine, cancer biology itself is a very big vast ocean. There is like there are many efforts going to acquire your ppm data in order to characterize molecular differences between tumors. Yes, it is very important to give why is it so important? Because you're going to stratify patients based on their typical diagnostic marker. It is very apparent, very several prove that suppose you have your precision and personalized medicine cancer treatment, it can result in a very better treatment outcome which could benefit the company, of course. And all these treatment strategies are very well governed by many regulatory agencies. And however, if this ppm personalized and medicine has to be addressed per se, it has to be part of your healthcare and insurance policies, and which should be become your part of the standard cancer. Supposing a CAR therapy, do you think it would be really affordable in a scenario like in India? It may not be, yes, but still, if you have a proper healthcare and insurance properties. So now, for example, a leukemia patient comes, we are going to give them a CAR therapy. Yes, this could be a standard cancer treatment regimens which should be inculcated in your regular cancer care protocols. So coming back to a regular story which we have already dealt this in detail. So if you go back, we know that there is a passenger genes, there is a driver genes. We know that driver gene per se is whatever it's exactly drives the gene, drives the gene which is responsible for the process of carcinogen. For example, you have an initial cell with normal cell with very few mutations. Then some intrinsic passenger mutations are acquired during normal cell division by intrinsic mutation process. Some very small mutations, but they could be eliminated. They will be eliminated by the process of during the as the growth. Then, however, you will be during childhood and adult. You will be having several environmental, for example, the pollution or sometimes the lifestyle exposures, like as I said, the asbestos workers, which make this passenger mutations. Then slowly you even have some driver mutations which will cause early clonal expansions, where this is like unlike before, the acquisition of a driver mutation is able to cause a clonal, you have some driver mutation, maybe continued exposure to the particular carcinogen or whatever, any genetic factor, any mutagens, all that you will have. As such, there is a typical cancer coming up. Now slowly we will get, this is the typical story. Wow, why am I talking about passenger and driver abnormalities here? Because this particular gene, the driver genes, could be your diagnostic biomarkers, whatever the gene which is responsible, the mutation gene which could be responsible here. So yes, if I can really look at this gene for during my diagnosis, maybe from, like as I mentioned, your FFP block or your blood or your cell-free DNA or ctDNA, if we can look for this presence of this DNA, then yes, we can really have a typical diagnostic marker. Then comes your slowly, now I will slowly shift gears here. Here it is like now we have introduced to something what exactly is your ppms, and then slowly we are going towards your driver's mutation. Now we know clearly what exactly we have identified. A driver mutation could be responsible for your clonal expansion, for your tumor, this thing, for the presence of tumor. Now coming to your field cancerization, isn't it like, a very fantastic term, which is like, it denotes a large variety of your regional changes on the surface of tissues. It was first observed in 1953 by Slaughter et al., where they proposed that the field of cancerization, in order to explain the statistical enrichment of the multifocal rather than isolated oral squamous cell carcinomas, as they found it in 783 patients with cancer. They were not, there are only some multiple foci. Then this is totally highly localized. What did they hypothesize? These patches are microscopically definitely abnormal, but the histological nature defines that they are benign, and the tissue surrounding the tumor suffered from the preconditioning of an area of epithelium to cancer growth by carcinogenic agents. You can clearly see it in the histopathology. This pathological evaluation of this shows has revealed that there is hyperplastic and dysplastic changes. There are pre-malignant changes found in the areas of carcinogen epithelium adjacent to the tumors, and these are termed as field cancerization. And just that these multiple foci of pre-malignancy could progress concurrently to form multiple primary cancers. You have a normal cell, then you have a cancerized cell, and then you have the malignancy. See how this is like, isn't it two fantastic terms? You have something called field cancerization, and then initiation of the cancerized field. So to understand, where does that initiation for this cancerized field happen? It is again like for the mutagenic insult, which I was talking about in my earlier slide. So for example, in the lung, especially in the bronchial epithelium, this is again your perfect example for a field characterization, where because suppose either it could be a genetic background, or with like or maybe exposure to smoke or to a potent carcinogen in the environment, it could trigger that. This, you suppose a sporadic lesion, a tumor does not share its tumorigenic mutation with the surrounding stream. This is where. Whereas a tumor growing in a cancerized field is the one that began from a malignant cell that initially shared your tumorigenic mutations and altered phenotype with your, it has an altered phenotype from the surroundings. Can you see how the phenotype is altered here? It's the same. Whereas it is, you are having your cancerized cell. Because the malignancy evolved because of an additional further mutation, further change, exposure to your carcinogen. So what happens? The whole cancer promoting microenvironment changes. So it favors the tumor growth. In that, the The cells harboring tumoric mutations may appear completely abnormal morphologically, like such as dysplastic, but the cells in the cancerized field, they will have an altered phenotype. That is first thing, they'll have increased survival. So per se, a cancerized field may be independently initiated by many cells following a mutagenic insult. Please use a very wonderful term here, mutagenic insult. Such insult may result to the consequences of your DNA damage, or by ultra radiation damage, or how will this insult occur? We have seen, right? We have micro, for example, your cigarette smoke. So these initiated cells may even could be small in number, maybe even in, it depends, well, and but they will clonally expand to create a contiguous patch of your cancer prime cells like this. Now, from this stage, if you remember in my earlier lectures, I was mentioning that to grow from this stage to this stage, it may vary from, for example, 1 year to 5 years, or even 10 years, or from at this stage also, if you remember, if our other repair mechanisms or whatever, they are all in the functional way, they all will be very well. This is a bit reversible. This is the replacement of the normal cell population by a cancer prime cell population that may show no morphological change, but it is now recognized it could be field cancerization is a prelude to the development of your cancer. For example, many cancers such as your lung, colon, screen, they usually mutations naturally occur, and they are clonally expand in aging tissues, but only very few of these mutations they increase the risk of cancer development. A cancerized lineage is one that has acquired but not all the phenotypic treatments required for malignancy is present. This cancerized lineage will have a survival or growth advantage over normal cells, but is incapable of growing into a tumor. So this is all like how this completely this normal cell from a complete cell. Supposing if you take any of your FFP or your biopsy tissue, or you test this particular cancerized lineage cells on a histopathological, yes, they could be, there are DNA changes. Yes, they could be morphological changes. They could be they could be even releasing certain metabolites into their environment. Yes, for example, the oral ones, the saliva. You will have certain biomarkers which are released into the saliva. Then that, you at this stage, yes, it is a typically you can detect detect the early prediction for cancer. One more term which we are using here is lateral cancerization, which is used to indicate the lateral spread of tumors because of the progressive transformation of the cells adjacent to your tumors, rather than spread and disrupting the epithelium by pre-existing cancer cells. This is exactly how it comes. You have a different. You have the normal exogenous factors which will cause for the clonal expansion. This is again very quickly I'm talking about free field cancerization in a skin model, where you have two paths for your UV induced squamous cell carcinoma. Here the first one is like it is like you have this exposure to UV can lead to cancer causing mutations and in the basal keratinocytes. Agreed, right? You have the TP53, we have discussed this, which are commonly seen in the precancerous keratinocytes derived lesions, which are called your actinic keratosis, AKs. So with additional mutations again in your genes such as the notch, this can progress to your squamous cell carcinoma. So this is how exactly one mutation, a small hyperplasia, and then you have your neoplastic squamous cell carcinoma cells. Now, what is the second pathway it was proposed, which can where the UV can directly induce your notch pathway in your dermal fibroblast here. This leads the cells to acquire cancer associated fibroblast like shape. That means they become activated. You have the activated CAFs. What will they do? They will release certain factors and fibroblast growth factors. Then they release lot of extracellular proteins and proteases. This results in the increase in the proliferation of the overlying epidermal keratinocytes. See how this increase is happening here. Then what will happen? Regions of this these particular regions will further become positive with CD45 positive inflammatory cells, which will contribute to your keratinocyte proliferation and the emergence of your actinic keratosis that can progress to your squamous cell carcinoma. This is again a very typical example of your field cancerization, and this is how we have explained in skin model, the skin using the UV light, which could be an inducer one for the squamous cell carcinoma. So now what are the different examples for of cancerization field human tissues? You have the colon carcinoma, where then you have the pre-malignant diagnosis in the dysplasia. You can clearly see different in mutations. We can see aberrant methylations, altered proteomes, and then yes, it is resection. What is the clinical, how do they take care of clinical resection of all the affected areas where area is necessary. And then you have the gastric carcinoma, where you clearly see interstitial metaplasia. There are mutations and there is aberrant methylation. So then there is it occurs in interstitial metaplasia, and has known pre-malignant state. Then you have the squamous dysplasia for your esophageal squamous carcinoma, where it is again evident by your mutations, then altered proteomics, then methylations are different. And then it is like there is a high possibility of metachronous lesions, and then this is mostly associated with your smoking. And similarly, you have with the esophageal adenocarcinoma, which has high evidence of implicated with development of a cancerized field. Then with the lung, the non-squamous cell lung carcinoma, where the lung adenoma, you have your dysplasia. Then again, you have the carcinoma. There's a change in the morphology of the tissues. Then yes, a lot of mutations, which we'll discuss in a lot in the coming session, or in some of this in this particular session. And then yes, suppose if it's a lung, it may not be a resection. Yes, it's not possible, because first thing, keep in mind here, for the lung, it is always only in the late stage only the patient will report to the hospital. Then smoking, yes, which can be seen widespread. And then a continuum, then you have the non-squamous cell adenocarcinoma. Now we are going to talk about another very important parameter, which we've discussed in cancer detection methods in detail, about cancer biomarkers. So very quickly, we will just go through the basic, which says it's a characteristic that is it is a characteristic that is measured as a indicator of risk of cancer. We discussed about HPV, high risk HPV DNA for screening of cervical cancer from your cervical grapes. And this characteristics of a biomarker can be a molecular, cellular, physiological, or image based. These biomolecules are found in tissues or body fluids, and they are produced by cancer cells or normal cells in response to cancer cells. Agreed. Biomarker testing in cancer, how do you get? You first need to have profile your tumor, or you can even go for your blood in case of your ctDNA or cell-free DNA, and then detect changes in DNA, RNA, proteins. That info, but all this particular profiling will provide information for efficient cancer diagnosis, prognosis, and precision medicine or guiding. Genetic testing, yes, because if you are in the inherited cancers, we come across this genetic testing, which is different from your cancer biomarker testing used for detecting germline genetic variations. So now cancer biomarkers are well defined. They are very well used for regular diagnostic protocols for cancer detection methods. Why are we talking about here? To get about a perfect precision oncology, precision diagnostics, these biomarkers are the ones which are taking the lead in the diagnostics market. You have your based on your disease state, you have the biomarkers, you have the prediction biomarkers, detection biomarkers, diagnostic biomarkers, and your prognosis biomarkers. And then you have the based on the biomolecules, as I said, DNA, RNA, your protein, and your glycoproteins. Based on other criteria, your imaging biomarkers, very, very important one, pathological biomarkers, and the in silico biomarkers, potentially you have, like, you for this, what material do you need? Usually the tissue, biopsy tissue, or then actually, and then you may need the peripheral blood or the bone marrow or the saliva or the cervical scrapes. Peripheral blood, as we have very well discussed into this, blood liquid biopsies, they've been proposed as novel promising strategies for the early diagnosis of cancer and to define patients' prognosis. Circulating tumor DNA is a fragmented released by tumors and found in the bloodstream and other biological fluids of cancer patients. So usually, if you can really take it, this particular ctDNA profiling, molecular profiling, it captures the entire tumor molecular profile. And first thing, it not only at the time of your diagnostic, maybe first time patient reports, but even, like, you can monitor your therapeutic response maybe 2 months after chemotherapy or maybe after radiation. Yes, you have definitely ctDNA molecular profiling, which really helps. Then you have the bone marrow aspirations to measure your MRD in chronic lymphocytic leukemia. So, despite offering the advantage of providing more accurate results than your peripheral blood measurements, always there is an important biomarkers for all this is, like, it's a non-invasive. You don't need to have the clinician, or you don't have to have a biopsy, a pathology, then pathologist, and all the other paraphernalia for taking the ctDNA and all. It's just a 2 ml blood. This is like predictive biomarkers. They are referred to as your response markers. They are usually very well utilized in assessing your effect of your administrating a specific drug. So, for example, any specific drug, for example, in the breast cancer, yes, can you have, yeah, predictive? You have the nanostring signatures or the BC360 markers. But they can, these biomarkers allow clinicians to select a set of chemotherapeutic agents which will work best for an individual uh, patient. For example, Herceptin. This is a very, very important agent used in breast cancer, which usually it's used in used for breast cancer lesions which are HER2 positive overexpression. Whereas tamoxifen is used for other breast cancers. Here itself, you have your, like, a HER2 positive will have Herceptin. This thus that HER2 is your predictive cancer biomarker for a subset of breast cancer therapies. Likewise, you have your Ernatinib, your Gefitinib for your lung cancer. So now, what is the predictive biomarker for them? Your EGFR mutation status. EGFR wild type, you give a set of drugs. Mutated ones, this particular Ernatinib and Gefitinib is given. Simple, what are exactly your characteristic of a good biomarker? You have, like, it has to be accurate, it has to be in measuringly object performance and measuringly objective. It should not be like the accuracy should be in very less quantities also. It should be able to precise. So it should be able to obtain. So very, very important aspect for your precision oncology, precision diagnostics. Then normal, when normal patient variability, when you have the change in measurements, it should be able to discriminate between the pathological changes and your normal changes from one human to another human. Sample to sample variation, it should be able to differentiate. and we should be able to correlate directly correlate to the disease to the measured effort. Then usability, ease and feasibility of evaluation and clinical translation. Now coming to a very important term in precision oncology is your companion diagnostics. This was companion diagnostic was first introduced in the late 1990s, with the pivotal point being the simultaneous approval of for 5 herceptin and its corresponding companion diagnostic test, your hercept test. These companion diagnostics are nothing but they are tests and assays used to detect biomarkers and specific mutations to elucidate your disease pathway. You can use them to stratify patient populations and target drug therapies. That are you can identify patients that are suitable for treatment. These CDX are in vitro diagnostic tests supporting the safe and effective use of a specific product. They will for example, suppose this particular companion diagnostics, apart from being identify subpopulations of patients that can benefit from the treatment or not, they avoid adverse effects in patients who may not be able to benefit simultaneously, so that thereby you can even reduce the cost. This is a typical monitoring and guiding diagram here, where companion diagnostic agents can be used for the diagnostics and treatment. This is like the only imaging FDA companion diagnostic is tool used in FDA is your Ferriscan, which enables your mRNA assessment of your iron content in the liver of patients with non transfusion dependent thalassemia. Because of this molecular imaging, you have the different, like you have the PET CT imaging, MRI, you have the all the different high-end images. Based on that yes, can you sure clearly, yes, for me your PET CT, all of us are aware, we can really go look at the tumor mass. This can, okay, sometimes yes, this PET CT is now currently being used, this optical imaging, to predict your therapeutic efficiency. This is very companion diagnostics is a very important in the era of precision oncology or precision medicine. Here you have your companion diagnostic development and then your treatment development. Both of this go very well hand in hand. It's not like one is independent of an other. You have, like, supposing you have the companion, you need to identify what is your biomarker selection. How is it feasible? Then you have to develop a prototype assay. Maybe you want to do a lateral flow assay, or you want to develop for example your saliva, or you want to develop a filter paper based assay, or you want to develop a DNA PCR assay or a LAMP PCR, whatever, and then after you develop your prototype, you have to do an analytical validation, clinical validation, and then it is like validated companion biomarker. It's this. What is happening with the treatment also? Yes, you need to have in the can is this basic approach. It's a typical target target selection here also. For this particular target biomarker, similarly, how was the response to the treatment? Prototype, you're having a prototype which is in the drug design and drug discovery, and then you have the preclinical development, where exactly you go for your mouse models or whatever models, the animal models, and then the clinical phase 1, clinical phase 2, phase 3, and then post approval and then launch. Can you have, if these two can really go hand in hand? So here you have to have a target validation, and then identification and stratification of your markers. Then here label considered based on your marker status, where exactly can it have. Then clinical utility for the stratification of your marker. How can it be? Suppose if it is HER2 positive, how is it? Or if it is negative, the clinical validation for stratification marker again goes through at this phase 3 also. Based on this trial results, it will be considered for further approval or and further development as a drug, for which you have your companion diagnostic marker. This is very important pipeline for development of your diagnostic marker development, as well as the a companion as a biomarker development, as well as your treatment drug development. So one very important part for a precision oncology, very vital part, is your molecular diagnostic, which is a very key component where it embodies the target and rational treatment of cancer according to the specific molecular authorization which underlies in the, which is specific to the particular patient. As we all know that cancer is a genetic disease which could be even inherited or acquired gene aberrations. So each cancer carries a unique set of your driver genomic aberrations that work together to promote cancer initiation and maintenance. We know this particular, which we have seen in the initial slide. Usually, sometimes these genomes are inherently unstable, and many accumulation of more new genomic alterations can lead to the cancer progression. We have seen in detail in the basics of cancer what are the different genomic alterations that can happen. One thing which we will stress is your single nucleotide variants, which are a class 6 class mutation spectrum, where this particular transitions has happened, where a single nucleotide CG to A to G or whatever, this particular 6 classes of mutation variants are there, and usually contributions from this each class is associated with distinct exogenous carcinogens exposure. So usually particular the CG to AT transition is related to smoking in lung cancer samples, and particular this transition is overrepresented in skin cancer. CG to TA is related to your UV exposure. This is called you have something called every cancer, or every cancer has got something called a mutation signature, very important. There are like this SNPs are have been possible classified into 96 possible combinations. As I have mentioned here, you have like DNA, RNA, and the protein, and the different analysis for individual genes, individual transcripts. This is like how your material, starting with this is like either you have from your FFP or from your urine or the saliva, whatever. Mostly the current used material is your FFP. Then slowly a lot of approach from the cell-free DNA, ctDNA is also gaining. Then you analyze for your it's a general practice where you analyze for your individual gene or set of genes. This is like you can even use your regular qPCR or a regular PCR, real-time PCR here in this case. Then individual transcripts, you have a set of transcripts. Then you have a proteome where you have the MALDI top. Then this is slowly evolving. Now, instead of taking a specific genes, how about going for an exome sequencing, transcriptome sequencing, proteome? This is all totally evolving in this, but in the current areas. But then you have the methylome here. So different, as I mentioned, you can even have your blood, cerebrospinal fluid, or the urine. All this particular but from this area, it requires, you have need a lot of resources. It has but there is a lot of scope, because you get lot of huge amount of data from this, and there is an importance of pattern. You definitely have, you have more ways of more data, you have more ways you can classify, right? You can have definite pattern recognitions here. This is the suppose how does it diagnostic tools, they are adaptive use of during the course of your disease. What happens in the patient's journey? They start for a treatment. Initially they start with neoadjuvant setting, with before the main treatment, with a goal of making the main treatment more likely to be successful. For example, your regular cisplatin, and then the specific adjuvant treatment. Then there is a if there is a relapse or a metastatic setting, you have the complementary tools, your tissue, where, and then the liquid tissue biopsy and your liquid biopsies here. You are more focused here. now in this particular journey of using the diagnostics. Such they will be these people, this liquid biopsies will be the ones which will be increasingly used during and late. See, for tissue biopsies, first thing usually they take it only during the time of surgeries or a CT guided biopsies. But whereas liquid biopsy, anytime, even if they come for your treatment also, we can take the cell-free DNA, take 2 ml of blood and look for the typical genes expressions and profiling. Now we look at mutational signatures. We've been talking about what are these exactly mutations, and we really now aware that single mutations can cause a change, result in a clonal expansion of cells, which will result in tumor. In addition to identifying your driver genes, cancer genomes, somatic mutations have been referred to as mutation and signatures. These signatures, mostly somatic passenger events, they reflect the mechanism of mutations which are caused by your environmental exposure to mutagens or deficiency in specific DNA pathways. Here, the first approach which will use your sequencing data sets to derive and assign mutational signatures de novo. The first approach. Mutational signature analysis depends on having you should need to have a sufficient number of somatic variants that fit an expected pattern. Mutational process that lead to hypermutation generate signatures that are more likely to detected from your clinical patterns. This is like why are we talking about this precision medicine, precision oncology? Because no two patients' cancers are exactly the same in many of the cancers, and many of these will have variable responses to genetic treatments such as your chemotherapy and radiation. It is like now your precision medicine is synonymously used with similar terms like your medicine, stratified medicine, individualized medicine, tailored medicine, and P4 medicine. Such wonderful terms. But this is completely in contrast to your traditional methods, which is more of evidence based in medicine, which in turn is from the traditional medicine. From your traditional medicine, you have the evidence-based medicine, then you have the stratified, personalized, and your individualized. This is like how the medicine concept, which is also reflective of your cancer oncology, precision oncology concept. What happens here? Precision medicine, it includes definition itself includes the concepts of both accuracy and very precision, highly precision and accurate. This is the way. Now, what is accuracy? It reflects your degree to which the result of a given test or confirms the correct value of to a standard. Whereas precision, it refers to how close the repeated measurements are to each other. You need to have a very good for your companion diagnostics, maybe a mutation signature to be used in your companion diagnostic marker. It should be very precise and accurate. This is like when we use a target shooting. So it is like accurate, but this is also, suppose this is the typical cancer and how is it? It's an ideal situation. But sometimes you have marker which is precise, very precise together, which are but shots clustered together away from your center. So both accuracy and precision are very essential for your precision oncology, for a good companion diagnostic biomarker. So both genomes should be faithfully represented and the genetic stage should be reproducible. This is not something which we would like it. It should be the aim of the precision oncology. First thing to aid in therapeutics. You even have therapeutics as much as you have the molecular signature stratification. You even have the therapeutics, which we will deal in the next class, where the individual characteristics are of that particular patient molecular signatures are sufficiently distinct and interventions can be concentrated on those who will benefit And those who may not, suppose you have a negative marker, or who will not, and you know that drug will not be working, definitely you will be sparing expense and unnecessary side effects for those who will not. The first generation of your clinical trials evaluating is the evaluating the feasibility of matching is a range of treatments to specific molecular features that can be measured in an individual patient's malignancy, has provided some notable success, as well as demonstrated certain limitations of this approach that will require improvements in prerequisites. This particular whatever therapeutic, it should be able to demonstrate, it should be able to measured in a individual patient's malignancy, and it should also provide that this marker should be useful in your therapeutic, to evaluate your therapeutic response. You have a group of patients here. So patient phenotyping, you will do standard clinical analysis, tumor biopsy, then you do your NGS, next generation profiling, and then the hostomics profiling. You have a different kind of genomic profiles. Then what will this precision oncology do? You have, each patient will have a different, isn't it a fantastic? You are using a very good diagnosis, not only diagnosis, a very good non-invasive procedure. This is a very ideal scenario for a clinician, where you can have all this will really aid in the clinical analysis. What are the examples of your precision therapy? The initial effort was like was to make discovery of your novel therapeutics. After that, through how did they discover? Through search of agents toxic against your cancer cell lines. We will talk about this in the drug discovery next class. But with there is an identification of specific cancer targets, such as your hormone receptors, such as your estrogen, progesterone, androgen, HER2 for your breast, and your VEGF receptors and others. EGFR targeted therapy is the best example for how can the targeted therapy can be magnetized. Such as initially your EGFR targeted agents, such as your gefitinib, berlotinib, were used for all non-squamous lung cancer patients only, but they found only few of them were benefiting. Small portion of this were benefiting from the treatment. Why? Because there is a realization only individuals with mutated EGFR only. This is like, go back to our first class where you have your tyrosine kinase inhibitors. Only these mutated inhibitor, if you have a mutated EGFR only, your this particular TKI inhibitors, these are called, they will be aiding in the response, a better treatment. Whereas those with wild type, another therapies are being explored. This is your example of your targeted therapy, where an activation of the, suppose you have an EGFR mutation, it will drive cancer growth that may be blocked by your EGFR inhibitor. This is the tumor cell proliferation. How this particular EGFR inhibitor mutation in this particular receptor will cause in the changes in the different signaling pathways. Whereas even here also, you a mutation from BRAF, where this is mostly for your thyroid. V600E drives resistance against EGFR inhibits and may be blocked by your BRAF and MEK inhibitors, such as your vemurafenib. Here, this is a EGFR inhibitor which will have the downstream sides of your RAS, and then the BRAC inhibitors and the MEK inhibitors. This is again a complete example of your targeted therapy. So very important slide here. Why are we talking here of this particular targeted therapy in precision oncology? Is because you are having a precise diagnostic, companion diagnostic markers, that is your EGFR DNA molecular profiling by using your qPCR, and then you have a specific drug. There are three aspects here. First thing, what is the source tissue here? Here you have even FFP or your cell-free DNA from the ctDNA from the blood, and then you have your then you look for the specific biomarker by molecular profiling of the DNA, and then you have a designed drug. This is a very fantastic 3-chain as per the model which I have mentioned before. This is the model which talks about, personalized medicine model, which can even be used for your precision oncology models. Usually you have there is a key differences in the traditional model of your cancer. First agreed, right? What are the traditional general earlier methods were? General procedure for cancer treatments were like chemotherapy, radiation, surgery based on whatever stage the patient approaches the clinic. But however, this treatment's efficacy is very varied across individuals and also often cause harm to healthy non-cancerous organs and tissues. So you have how is this is the after the diagnosis of the tumor detectors. Then you have the PPM, personalized precision medicine model, which is characterized by individualized treatments and as well as individualized diagnostic approach. Suppose you will have your sub tissue, then metastasis like your breast, the luminal and the non-luminal, then the bone, the skin. Each one will have your targeted treatments. Then you have the immunotherapy. Then very important is your omics analysis, your genomics. For just imagine 2001 or the whole human genome project was completed. People thought it's a revolutionizing event. For that it can benefit mankind in many ways. Yes, when for the this whole genome project is very useful for the NGS applications for cancer diagnostics projects. The companion diagnostics can help which treatments will most effective for a specific cancer tumor, and novel cell therapies are used to target the cancer with minimal damage to healthy tissues. So this is very important. This is like you should link your tumors to the effective drugs. Then the genetic mutations, like as we have the BRCA, we have seen the HER2, the EGFR, and then the personal factors such as your environmental risk factors are also play an important role in this your personalized precision model. So usually this is the despite this, even though much we are talking about, still chemotherapy is the standard point of care treatment strategy for many different cancer types, and often sometimes it could be the only treatment that many of the patients, especially in your low treatment setups, receive. This is like sometimes this treatment strategies could not be, chemotherapy cannot be effective in many of the cancer patients. What is the goal of your precision oncology? You have a very important drug, you have a very important diagnostic biomarker. What is the whole goal? It is very important to understand the molecular mechanism of your cancer formation and how that individual unique characteristics will aid in its progression, or how the therapeutic response can be minimized and maximized and then minimize your treatment side effects. You can have this precision oncology can be used for the discovery of several novel driver oncogenic pathways in the tumor of an individual. Then you have expression assays to maximize therapeutic response. This is like optimize. So the goal is to optimize your anti-cancer effect of the drugs and minimize toxicity. This is a predictive model development from your large scale omics. As I said, you have your loads of data which is generated from your omics, that is your transcriptomics, your proteomics, and your whole next generation sequencing. Then you even have several portals such as your TCGA portal, then your CBI portals, all that, where all this data are reposited. Then you have an in silico model. Do you define a functional network architecture, multiplexed activity profiling, then it is validated. You have the component level data, theory level modeling, and the system level data. Very importantly, we use it is very important any of it to go through your animal models and go through clinical trials. The PPM model, first step is acquiring your data, as we have discussed, like using all this particular tools, and then to characterize the initial individual's disease state, and then understand and application in tools in clinical trial design and treatment in the selection are important. And then emerging cancer products, such as you have your organize your monoclonal antibodies, cancer molecules, and CAR-T, cancer vaccines and CAR-T cells are also from the PPM perspective. Then you need to have federal regulations for PPM products to so as to ensure that they are safe and efficient. Then you need to have broader consequences. What are the broader consequences? Very, very important is your economical and ethical concerns of PPM are have to be considered. From an economic point of view, this is PPM is very difficult. And then the niche can also be from the ethics also. It you really have to take a lot of precautions for by protecting the privacy and of the health and the targeted and patients. It's just not like first thing, we have to be very, very important in this fact. Particularly, you need to have strict laboratory SOPs in place, several accreditations in place to really ascertain that this particular drug is yes, it is, or this particular biomarker is wild type or mutant. Yes, can we use this? It's a very, very it is a very much onus responsibilities of all hospitals and organizations which take up this precision oncology or targeted therapy. This is again similar to what I was mentioning before, the transcriptome genomics, transcriptomics, proteomics data. They will be acquired, metabolomics, then your data is stored, and from this data you will develop a PPM theory where the data is processed, interpreted, um, and predictive model. Then outlook for cancer PPM, you use organize your monoclonal antibodies, and then you will be regulating PPMs using FDAs and several, all your ethical organizations come here. Then you have broader consequences, as I mentioned, economic, where savings from patients will be from can how does it work with your pharma companies, and the ethics. So you have different, definitely now agreed upon, you have comprehensive diagnostics for patients with cancer. So for comprehensive diagnostics for patients with cancer, first they characterize the genome of patients using a state of your art technologies, as I mentioned, all the omics. Then you have to filter the first thing, where is the tissue here. For example, here is your lung biopsy. This could be archived. Biopsies can be stored for several months to years. And it is like you have to, after you characterize the genome of the tumors, the genome data through a knowledge base of existing and emerging anti-cancer drugs. And third, present and annotating list to the treating oncology that can be incorporated into the, you will have after you profile this particular tumor or whatever, it should be presented to the treating oncology, based on which they will really have they will design the treatment strategies. This high quality genomic information must be very much consistently obtained in the diagnostic setting, and that too from very old FFP blocks also. You have category of alterations. You have many, again you have the tier 1 FDA approved drugs, and many of these drugs, sometimes of them are in clinical trial. Then you have prognostics, and then variation of uncertain significance. This is a typical example how you develop preclinical tumor models for use in precision oncology. Usually you develop mice models. They are usually patient-derived xenografts. You use nude mice mostly. This is how you develop preclinical tumor models for precision oncology. How do you do this? You have the different individuals with the, say for example, different tumor, maybe just take for example breast or a lung. The tumors are taken either from surgery, during surgery, or from biopsies. Then you have the blood CTCs or cell-free DNA also, which can be taken. And then the techniques for separating large amounts of your CTCs and cell-free tumor have been very well standardized. And then and they represent, this is like they are the viable approaches for obtaining your malignant tissue for DNA sequencing and for pharma. From this stage, what will happen? You put this tumor into the mice, or then you generate organoids, for example lung or the breast organoids, which are just that you're growing the tumor in vivo. Now what's happening, this particular tumor, you put it a patient derived xenografts, you put it in the mice. For example, you're giving say the same cisplatin drug to the patient, and you give it to the mice also. The tumor response to that particular drug in this mice is an response or an indicative response how the tumor will survive in the patient. For sometimes, the tumors will overgrow the mice, then the drug is not acting on the tumor. That means what will happen? Yes, it may not. There is a possibility that even in the patient also the tumor will be overgrowing. It gives the minimum preclinical indication. Suppose you want to try novel drugs. Yes, these are all very, very important. Mouse models are very, very important. Then after that, you can clearly see you have your how the mice are preclinical trials modeling, how the different mice are stratified here. You can see the blues and the reds here. Now it's patient-derived xenografts, tumor organized and conditionally reprogrammed low passage tumor cultures. They can be either see, even you can have tumor cultures also, small bits of your tumor from here, you can grow them here. See, can you see all this? This diagram is very small. How all this growths are grow, and then you can directly treat your drug in this particular plates or directly on the tumor, and then you can say that you can give, suppose I want to try a novel inhibitor along with cisplatin. Can I do that? Is it going to that I can reduce suppose I want to use natural compound along with your tamoxifen. Can I reduce the tamoxifen storage? Yes. Instead of directly doing cell lines is one acceptable model, but one more is your mouse models here. We will discuss. Then you have this imaging. These approaches, even in the low passage numbers itself, you can very well. So for example, the tumor from here may be very small, but if I can do a passage number 1, 2, then I can really have a molecular characterization of this particular. I can take this tumor, I can do a sequencing, and then drug screening. All this I can completely do it in this particular using this models, and I can even do imaging also on the PDX models. So now, so as I said, this is like a clinical, non-clinical models for your targets. Then you have the translational research with your clinical models. Patients, eligible for early or site-specific clinical trials. Then you have the analysis. You do the sequencing as I mentioned it before. So patients assigned to trial based on molecular characterization. So based on the molecular characterization of this tumor, maybe the tumor material could be very small to directly go for sequencing. Then that is why you put it in a mouse model. Then patient modeling. Then patient monitoring, post all this, the mouse. For example, as I told you, if the tumor is able to overgrow the drug in the mice, it's not likely it can happen even in the patient also. You have the real-time monitoring parameters such as your mouse. Then you can even see how your CTC, CECs, that all this enrichments, then tumor initiating cells can be seen. That is in the clinical observation. Repeated tissue acquisition during therapy and at the time of your disease progression correlated with clinical assessment of efficacy and toxicity. This will help to understand the specific mechanism of your drug select sensitivity and resisting operating in each individual, specific individuals. Now, how do you develop a ppm model. The current personalized precision model is proposed to precisely classify patients into subgroups which share a common biological basis of disease for uh, more effective tailored treatment to achieve improved outcomes. So you have your disease subtypes 1, then subtypes, then you have the subtype 2, and then you have the subtype 3. Tailored treatment. You have the tailored treatment for subtype 1. Then for each subtype, just imagine this is the very fantastic scenario. With the very much increasing in progression in various omics and then in your targeted therapies, functional precision medicine models, comprehensive health records and big data in the last details, they are able to divide. It's very, very important, very well divided. Can you see all this? How you have the tailored treatments? Is this an imaginary line, whatever we are drawing around precision medicine? Or can we have any different consequences? Some people definitely, the truest or the purest of the cancer biologists may not really agree upon where it's like, can it be how it is very important to differentiate precision medicine from your genomic medicine, because or it's just not an extension of your genomic medicine. But definitely several important parameters like your your electronic health records. Now all hospitals have this health electronic data. So and then telemachines, then internet information communication technologies, they all have to be very well in place for precision oncology to be in working in. How does it, this precision oncology or precision medicine, how does it work in terms of improving population for population health or your PH? But it is not very, it did not happen really very relevantly, especially in cancer. Yes, your HPV cervical HPV screening for cervical cancer, high risk HPV screening, which we have done, that is really gaining momentum. And but this but still it's not a very lot of application in this application has to be extended for other cancer screening protocols also. What is the path for this particular precision medicine? So many drugs have been developed to fight the disease in several ways, such as you have the inhibiting enzymes that signal the abnormal growth and survival of cancer cells. There you have drugs that block your aberrant gene expressions, characteristics of cancer cells, and there's drugs which halt molecular signaling pathways that are overdrive in cancer cells. These are all your key inhibitors. Very important. It's like what are the existing inhibitors for in oncology and the different times. From the 90 and 70 we have the tamoxifen for your ER positive breast cancer. Then you have the trastuzumab for HER positive HER2 positive breast cancer, and then you have the in the this happened in 2000. And but whereas in 1980 you have the oncogenic DNA which is isolated. This and again very then from 2000, this is when I was mentioning 2001 about when the whole genomic sequencing was completed. NGS became a very important tool for your precision oncology. And then you have the specialized gene panels for breast cancer, where you can select examples such as your oncotype. Then you have the mammoprint, the prosigna, very important, that is using your nanostrings. All these milestones came around this point of time. For this, what is the different drugs? Okay, Mantabib, see where for your imatinib for your CML and BCR-ABL translocations. For this leukemia they have given, and very important, you even have your gefitinib here, which was discovered for your EGFR mutant non-squamous cell lung carcinoma. Then you have the cetuximab, the EGFR mutant CRC colorectal cancer. Then here what milestone did we achieve here in this point of time? Gene specific genomics sites. where you have your Cobas 4800. This is V500 600 mutation testing. Then you have the Cobas EGFR mutation placed. Then BRCA analysis. Then extended RAS panel. Very, very important. We have come up with many panels around this period. But at the same time, the different drugs, what did you have this year? Vemurafenib you have. That is your BRAF, for your BRAF mutant melanoma. Then, uh, then you have for this particular drug. Then you have pembrolizumab for your and then this is all again for your ALL. This is again, you recollect, we came across this for your during your CAR T therapy discussions. Then larotrectinib, that is for your then we have sortinib for your KRAS cancers. So 2020 different, and then again the NGS based CGP panels you have, where you have the different targets and then this particular drug. Well, this diagram has been able to illustrate. Then you have the select examples, like you have of course you need the FDA approvals, then the European Medical Association or the whatever the different country guidelines have to be given. And then you have the HGBS recommendations for the description of your sequence variants and all that. This is a very, very important diagram which predicts your the biomarker uh, development, companion diagnostics along with your therapeutic drugs diagnostic. This is again which will we will be talking about this also in detail in future, where the disease biology, then you take the sample, and then sometimes you may have hard to treat tumor types. For this samples are can be circulating analytics, and then you have the multi-omic profiling of the whole tumor. You can do that. Then you find new targets, new therapeutics are continuously evolving. This is a completely how the whole next generation precision genomics is evolving. And then you have access to testing and treatment. Then again you go for your tumor heterogeneity again here, and again go for your profiling, and then data handling. And it should be, this whole treatment strategy should be given to of all strata of people, and then you counsel the patients. This is the disease etiology, then you have the drug development, and then the molecular diagnostics and the cancer clinical trial design, the clinical trials. We will all be talking in detail in the next class, and the treatment decisions. This all is lying with your tumor board, the hospital tumor board councils. And then you have again monitoring here where you come across, where you bring in adaptive trial design. Maybe should I use the old chemotherapy along with again and another adjuvant therapy, for example in the CART, how we have seen, and then you have to standardization, and then clinical evidence of an improvement in treatment, or are there any risks associated with this particular precision oncology, maybe the drugs. Yes, the patient should be aware, and then it should be done not only in one set of populations or in one set of countries. It should be done in across all global collaborations. It should be done. The precision medicine definition, it should not only include an individual, but it should be very realistic and should have impactful decisions, and one should it should be at the level of population and the population's individuals. Even though you have genomic medicine such as strategies such as improving your diagnostic methods, your your precision medicine, it should preventively care for high risk population by detecting early risk concepts such as your cervical, lung, and even prostate and breast. The precision medicine should be starkly differentiated from your genomic medicine to investigate, access, and implement the benefits of precision medicine beyond that of your genomic medicine, so that you can serve more population. How about naming it as precision population medicine or precision population oncology, which could be the future direction where you have it is love for natural. First step is to um, it would be to encourage an intentional change in diction used in conversations by clinicians. That should be this precision medicine to be oncology to be should be integrated as a normal part in the when the clinicians take a decision for their uh, for for the therapeutic, and it should be also be encouraged by the policymakers to make a similar change which may be more likely to be to help conversations by clinicians, researchers, and educators in the concerned field. This just depicts the context to explore barriers for clinical practice guidelines. You should have usefulness. It should be evidence based, access, structure, applicability, and then compatibility, relevance, legal. It should have legal implications. It shouldn't have strength and quality of education. Then health organization should, and from the health organizational system approach, it should be provision of services. It should be able to generate resources, financial and administration provisions, and availability of guide. From the should be it's like political and social interest. What is a level of support of disagreement, and then opinion of colleagues. When there is how can it if there is a disagreement, maybe if there is a test discrepancies, or if there is like discrepancies in the term of mutual trust, level of communication. These are all very, very important contents. Of course, with other oncology practice also is important, but with precision oncology, it is all the more because you are having various parameters to screen and various drugs to give. So it is very, very important. So from the health professional context, they should be really competent enough, skill, knowledge, and very well. From the patient contest to make it all, he is the most center part here. It should be fulfillment of treatment, then doctor-patient relationships, needs. They need to have the awareness of the disease, attitude, and they should be motivated. What could be the challenges for precision oncology? So it's a relatively a new disease prevention and therapy method with a valuable ability to consider and integrate your varying genetic, environmental, and social factors. But public health funding, especially in scenarios like in India, it has to be devoted to the current advance in your precision oncology, such as, for example, you need to have your NGS sequencing. How much does it cost? One panel for a lung panel, or for your or colon panel. So it would cost 1 lakh per test, because your maintenance charge for the instrument, everything is quite expensive. How does you have the public health funding that can be devoted for this particular field? Yes, it is a debatable topic. And then not only for testing, even you need to have counseling also. So you need to have even your paramedical workers, or even the who are all completely aware of this precision oncology or the precision medicine. Always this whole field has been continuously questioned to determine its utility. It's not necessary that maybe I have given an EGFR TKI inhibitor to a EGFR positive individual. Yes, he will have a better outcome. Not necessary. It as always with the cancer being the aggressiveness of the disease. Yes, there is a very high chance even that could also be a failure. Then how do you have the how do you really support with such? Because once you have a novel drug, definitely there is a chance that the that particular tumor could become even resistant to this particular drug. Now, how does it how does it really aid in improving your health improvement? Yes, this is something which is a real challenge for precision oncology, of course, for cancer tumor per se also. Then this critics primary concern, can this yield health improvements for the general population? As I mentioned, can it really have it's no longer like even ppm also. It is like should be for population health also. And can this be used for your towards allocated towards conventional public health measures? We have come to the end of this particular session, and where we have really dwelled into the complete complete definitions and exactly what is precision oncology. Maybe given the title of the course, it should be like maybe we take this session first, but because we have handled the basics, the complete detection methods, everything in detail, I thought this would be a right thing to make it now at this juncture where you are in midway, so that the further targeted therapies whatever we have designed for this course will be very useful and helpful in understanding. So in the next class we will be talking about the drug discovery process in precision oncology. We will talk about the different the non-clinical models that are adapted, and the different types of the clinical trials which several researchers used for the identification of this targeted therapeutic drugs. Thank you.